Well, I'd like to welcome everybody to the treatment of opiate use disorder, January 26th. We're just going to give another minute or so for allow time for others to join. Again, I would just like to welcome everybody this afternoon, treatment of opiate use disorder webinar. We will begin in less than a minute. Good afternoon. Welcome, everyone. My name is Ken Lanning, and I am the Regional Resource Director for Long Island at Caron Treatment Centers. Thank you for joining us for today's webinar on the topic of treatment of opiate use disorder. As a reminder, we will be conducting this session in a webinar format, meaning all participation will be muted. We will not be able to hear or see you. During the presentation, please utilize the Q&A chat features to ask any question. Depending on the volume of the questions, if we can't get to your question before the end of the hour, we will have someone from our team follow up with you directly. Today's presentation is eligible for one continuing education credit. We would like to thank our educational partner, CE Learning Systems, for assisting in providing these credits through our co-sponsorship with the American Psychological Association. Please note, you must be on for the duration of the webinar in order to receive your credit. Please also note that in order to receive your credits, you will need to complete the post-webinar evaluation. A link will be emailed to you directly after the presentation from cego.com. After completing the evaluation, you will have immediate access to your certificate of completion. Today, I am proud to introduce our presenter, Chris Owsiany. Chris Owsiany is the Clinical Director of Men's Phase 1 program at Wernersville, Pennsylvania campus. Chris joined the team at Caron Treatment Centers in 2002 and has worked in several clinical positions with a variety of patient population. His areas of expertise are teens and young adults, clinical supervision, and professional development, as well as family therapy. Chris obtained his bachelor's degree in psychology from Elizabethtown College and Master of Arts in Clinical Counseling from Alvernia University. He also holds certifications through the Pennsylvania Certification Board as both as an addiction counselor and a clinical supervisor. Well, please, everybody, I'd like to give a warm welcome to Chris Owsiany.
Thanks a bunch, Ken. I appreciate it. Thanks to all of you for joining us today. I sit here in Wernersville, Pennsylvania at noon local time. So if any of you happen to be joining over lunch, again, thanks so much for doing that. Thanks for taking the time. If you're not having lunch, we thank you for joining as well. But really appreciate the opportunity to talk and hopefully raise some awareness today about a really important topic, the treatment of opioid use disorders. If you're joining this talk, you probably know that we have a major opioid problem in our country. Lots of nasty consequences, death, et cetera, et cetera. So we'll go through some of that today, try to define and quantify the problem a little bit. Hopefully try to understand what are some of the risk factors for opioid use disorder, identify who most often misuses opioids, what sorts of characteristics do those folks have. You can't talk about treating opioid use disorders without discussing the use of medication and treatment. So we'll spend a fair amount of time on that. Hopefully understand, how it helps and, encourage everyone who's on the session to think about your own opinions and your own sort of beliefs about using medication in the treatment of opioid use disorders as well as other conditions. We'll also talk about other ways, people are getting treatment, other things that we do in treatment to help folks, because while medication is important, it's not the whole story. It's not the only thing we do to try to help folks who have been addicted to opioids. And then finally, look to spend a little time examining the impact of stigma on not only folks that have opioid use disorders themselves, but also professionals, and how all of our beliefs that we bring to our job every day might impact the work that we do. Um, Maybe just look at things in a bit of a different way if possible. So hopefully we'll spend some time understanding the problem, and then before we're done, come up with some ideas on how we might be able to help. So we have a great need for the treatment of opioid use disorders. That's obviously an understatement. Again, if you're on the training, you already know that we have a need to treat opioid use disorders. But we really do, and they're different from other substance use disorders in some ways, and they're also similar to other substance use disorders in a lot of ways. There's a lot of overlap, but there's some nuances that are important with folks that have gotten caught up in the use of opioids that are a little different from other substances. So I wanted to start, you'll see opioid at some points, you'll see opiate at other points. If you're out in the field, you probably hear both. Wanted to just right at the start, make a distinguishing point between the two, even though the words are often used interchangeably. Opiates are with a T, opiate, derived from plants like the poppy. Opioids are more synthetic. So things like Vicodin and Oxycontin and Percocet would be opioids. Things like opium and heroin would be opiates. So just a minor point. Again, throughout this and other work in this area, you probably see both opiate and opioid used. So that's a difference there. So in the calendar year 2019 in the United States, these are some grim numbers as it pertains to the use of all sorts of different kinds of opioids. And numbers are nice. And to me, though, it's helpful to have some context around these things. So I want to give you some just some other numbers that compare these two, which to me made these things sort of come alive even a little bit more. So 1.6 million people in our country had an opioid use disorder. So think about whatever the closest large city is to you at this point. For me, as I sit here in southeastern Pennsylvania, it's Philadelphia. That's about the population of Philadelphia, 1.6 million. So imagine every resident in the city of Philadelphia with an opioid use disorder. That's the situation we have right now. 10.1 million people misused prescription opioids. Again, to give it some context, the population of New York City, about 8.5 million. So that's more than the population of New York City misusing prescription opioids in the year 2019. 50,000 people use heroin for the first time, and almost 800,000 people use heroin overall. That's about the size of Seattle. So everybody in the country, or sorry, in the city of Seattle, if they use heroin, that's how many folks use heroin in the year 2019. So big numbers. I mean, they look like big numbers on the surface, but just again, to give it a little context, that's how many folks 2 years ago were using opioids in the United States. Again, if you're on this training, you probably already know there are many deaths as a result of drug overdoses overall, but opioids in particular. So here's a graph from the CDC showing the increase in opioid deaths really over the last 20 years, from 1999 through 2020. You can see almost 70,000 people died as a result of an opioid overdose in the year 2020. I think there's a lot of factors that go into this, not the least of which is just access to chemicals. If you think back, depending on how old you are on this conversation or on this presentation, if you think back to 1999 and what your computer access looked like, if you were going to get online, you maybe had to use America Online. You maybe had to dial up, you maybe had to be sitting at your desktop computer in your office or your bedroom or wherever. And think about how those things have changed now. We all have access at our fingertips, really 24/7. So that's a big deal. I think access to opioids in the last 20 years, as well as other drugs, has just gone through the roof. So we have a lot of people using drugs that might not have been before, and a lot of folks gaining access to drugs in a much easier way. So in addition to the deaths that we've already talked about, there are many other consequences that come along with the use of opioids, right? We've got a variety of medical consequences. Folks have conditions that will develop, withdrawal symptoms that develop, discomfort that develops as opioid addiction progresses, family consequences, right? Anybody, again, if you've done any work around folks with substance use disorders, you know of the toll that substance abuse takes on a family, right? It's not only the individual who's using, but it's the other members of the family as well, the folks in the household, even folks not in the household that are connected to that family member. Work consequences. People miss work because of drug use. In my position in inpatient treatment, folks obviously are coming to treatment for a month and miss work, but above and beyond that, many folks have been out of work because of their opiate use, using when they don't have time to recover or being under the influence on the job. So many work consequences, school consequences, the same thing. Young folks using opioids and other drugs continues to increase. Legal consequences, folks get in trouble with the legal system. And of course, financial consequences, people using, money to purchase drugs and do other illegal activities that, would otherwise have been better used for more healthy alternatives in their life. So a variety of consequences connected to opioid misuse. I'm sure you can think of others, but those are just some that we are hoping to address when somebody looks for treatment, really in any setting, whether it be outpatient or inpatient. Consequences needing to be addressed. So some risk factors for somebody beginning to use opioids. We know that the earlier someone begins to use, the more likely they are to have trouble. Their brain is developing, their interactions with the world, with friends, with family are taking shape. So the younger someone begins to use, the more likely they are to develop a substance use disorder. Early and persistent behavioral issues, rebelliousness, trauma, emotional distress. So other behaviors above and beyond just the use of the drugs, right? If someone's getting into trouble with school, someone who is defiant, with other authorities in their life. Trauma and emotional distress, and we'll get into that in a little more detail as we move along here. But those are precursors to develop an opioid use disorder as well. A stressful neighborhood or living environment, again, somebody who might need to sort of check out, who might have trouble coping with, negative emotions, with stressful situations, more likely to develop an opioid use disorder. Mental health issues, somebody who might have depression, anxiety, ADHD, bipolar disorder. All of these things put somebody at a greater risk for an opioid use disorder. Peer use, availability, low cost. Availability is a huge issue. If this becomes a norm in someone's life, in someone's environment, we know that it's more likely that they're going to continue using as they grow, as they get older. A positive attitude towards use, low perception of risk. Again, if someone is of the belief that they will have few consequences, or if this behavior is normalized amongst friends and especially family, that puts somebody at a higher risk. You see the next point, favorable parental attitudes towards you. So if this is something that's sort of normal in someone's family system, something that is tolerated within the family, that puts somebody at a greater risk to continue use, to develop use. Genetics and predisposition, so somebody who might have substance use in their family, especially excessive substance use. They might be socialized to this. They also might have some biological predisposition to find substances on their own. Poor school performance, starting later in elementary school, perhaps a lack of commitment or a lack of connection to school. Somebody who might not feel school is important, who might not feel that they want to devote time and energy to school. That's another risk factor for an opioid use disorder. And then the last one on there, for all of you that are already doing treatment with folks, I think is important to note as well. Leaving treatment prior to completion of treatment puts someone at an increased risk to go back to an opioid or to develop an opioid use disorder. So, and again, we'll expound on some of these as we move along this afternoon, but these are some areas that put people at increased risk. And if you're doing treatment, ways to think about, where on here might I be able to intervene, regardless of what my role is? What might I be able to do to help steer somebody away from some of these things, to help somebody cope with some of these things, to intervene on not only an individual, but maybe a family as well. So some things to keep in mind as we move along. So opioids are called painkillers, right? And they do a really good job of killing pain, which is, of course, a double-edged sword, a blessing and a curse, right? A pill takes pain away, but it comes along with some other consequences. So we try to think about who might be more likely to use a painkiller. Somebody who might have pain, right? And what kind of pain might that be? Emotional pain, physical pain. When we work with folks, we have them sort of constantly check in with themselves in 4 important areas. And this is always addressed when someone is in treatment as well, but we try to help them understand, what are they thinking about mentally? How are they feeling emotionally? And what are they experiencing physically? And what's their experience like spiritually? So you think about how a painkiller might really alleviate pain in any one of those areas: mental, emotional, physical, or spiritual. And while it might be sort of a quick help, it might alleviate pain in the short term, it oftentimes creates more issues moving forward, creates more problems moving forward. So it becomes our job to help people be able to cope with that pain, perhaps without a painkiller, or at least under the appropriate medical supervision. So I would encourage you to think about that as well, right? At its base, an opioid is a painkiller. So folks that are abusing painkillers have some pain that needs help with. So I want to look at two specific factors here around opioid use, and 2 factors that dramatically increase someone's likelihood that they might become addicted to an opioid. So the first is chronic pain. And here's a study from the Journal of Substance Abuse that examined over 5,000 patients in a large healthcare system that found that 64% of patients with an opioid use disorder had chronic pain. So that's a large number, obviously. And again, if we're talking about opioids as a painkiller, it would make sense that folks with chronic pain would want to use an opioid, right? It takes away chronic pain. Amongst those, 61, almost 62% had a chronic pain condition before their first opioid use diagnosis, right? So this is a story that, many of us see over and over. Somebody has pain, maybe surgery, maybe an injury, and they would receive a prescription to use some sort of opioid painkiller, in such a way that they would have some relief from this pain. And then all too often somebody uses it, might become addicted to it, and might have a hard time coming off of it when the time is right. So chronic pain as a factor, it cannot be undersold. Please be aware and stay aware of chronic pain. Trauma is another area that especially puts somebody at risk, not only for an opioid use disorder, but for other substance use disorders as well. Study out of the Journal of Anxiety Disorders, those that they studied that had a post-traumatic stress disorder diagnosis, you see the numbers there. 42% had an alcohol use disorder, 38 nicotine, and 22 for opiate sedative or stimulant use. So again, folks with trauma and all of the emotions and all of the consequences that come along with trauma tend to reach out to substances and tend to lean on substances at times to alleviate the symptoms associated with that trauma. So if you're working with folks in therapy, again, please be aware if trauma is a piece of the puzzle, if there's anxiety related to trauma, if there's shame, especially related to trauma, opioids can be a place people will look for help. Wanted to note relapse rates amongst opioid use disorders as well today. They're off the charts. And depending on where you look, you'll find different numbers, but they're all much higher than any of us would like to see. So opioid relapse rates after somebody is detoxed, that first bullet point there, up to 70%. So think about that. Someone goes through the sort of difficult process of detoxifying from a painkiller, and up to 70% might return to use. Even higher if we're talking about heroin. So relapse rates are quite high, and we'll talk through some ways that we might be able to help people prevent returning to use. So it's good information to know. If you're working with somebody with an opioid use disorder, the chance of them relapsing is great. Especially as we talked about before, chronic pain being such a significant issue. Those with chronic pain 3 to 5 times more likely than those without chronic pain to return to opioid use. Again, we need to find a way to help people who are in pain feel better. We need to find other ways for people to manage their pain. Physical pain often manifests in other ways as well. Depression, anxiety. So this is a job for all of us, really, whether you're coming to this from a medical perspective or a counseling perspective, a spiritual perspective, a school perspective. There's lots of room here for all of us to find ways to intervene. So we'll spend a little time talking about how we can help now. One of the great tools that we have in the treatment of substance use disorders is the American Society of Addiction Medicine. Their website's there at the bottom if you want to check them out. But we lean on this quite heavily in the work that we do here to try to help conceptualize a person who has come into treatment. These are the 6 dimensions that we look at. These are the things that we try to develop some plan for. I think they're great because they would call on us to examine a person's strengths as well as their areas of deficiency. So try to lean on things that folks already have that are going well, but then also identify the problem areas in these places as well. So again, the American Society of Addiction Medicine provides this for us, and they are ranked in order of importance as well. So dimension 1 being sort of the most pressing need somebody might have when they come into treatment, on down to number 6. So dimension number 1, acute intoxication and or withdrawal. So again, that's somebody who's presenting for treatment, and what sort of shape are they in? physically as they present to you. Are they in acute withdrawal? Do they need medication or support around that? Are they currently under the influence and need, time to clear before you can get involved in other treatments? Dimension number two, biomedical conditions. So that's other health conditions somebody might have. Dimension number three would be mental health concerns, emotional concerns, cognitive concerns. Dimension four, someone's readiness to change, how motivated are they? What's their motivation like? Dimension five, their potential to relapse or engage in other continued problem behavior. And then dimension six, their recovery environment. So that's a real brief overview. And we'll spend a little time now going through those 6 dimensions and try to understand how we can intervene on all of those dimensions, really. So dimension one, this is where I want to talk a little bit about using medicine for treatment. And I'm going to do my best not to say MAT. We'll talk towards the end of the presentation here about how some of the words we use around treatment can be stigmatizing, and MAT is one of those. So I'm just going to call this medication 101. So there's a host of different medicines that somebody might use to help treat a substance use disorder, especially an opioid use disorder. So I'm just going to explain each of these briefly for you. So the first one on there is methadone. Methadone is characterized as a full agonist in terms of the kind of medicine that it is. So that means that we have receptors in our brains that look for opioids. It will bind to those receptors fully, and it will offer a moderate effect, not the same kind of effect that somebody might get from heroin or from Vicodin, Percocet, Oxycontin, but methadone will offer something of an effect. The person will feel it. There'll be perhaps a slight euphoria. It operates much more slowly than most of the drugs somebody might abuse. The heroines and Oxycontins and Vicodin, et cetera, et cetera. But it is, again, it's a full agonist, just as those other drugs are. The next one down, buprenorphine, partial agonist. So operates differently than methadone. So there are, again, these receptors that we have, and buprenorphine would bind to these receptors partially. It wouldn't give the same sort of euphoria that somebody might have if they were abusing, heroin or something else, but it would fill the receptors in such a way that they wouldn't feel those real difficult feelings that come along with withdrawal. All right, so that's buprenorphine. That comes in usually either a pill or a film that somebody might hold under their tongue. Sublocade is also a partial agonist. This is a drug that is similar to buprenorphine. This drug is injected into the belly area, the muscle tissue, and lasts for a month, which is really tremendous when you think about one of the major problems with using medicine in treatment is compliance to medication and having someone ensure that they show up every day and take their medicine. So if you use a product like Sublocade, the person would have this injection and it would be present for the next month. It also provides the drug in a steady stream to the person, as opposed to, if you're taking a pill, you would have sort of this kind of choppy up and down. You would have the effect and then it would go away. And then when you get your next pill, have the effect, go away, get your next pill, et cetera, et cetera. So Sublocade helps prevent that problem because, again, the person has the injection and it stays with them usually for the duration of a month, sometimes longer. But that's Sublocade, which is like it has buprenorphine in it. Naloxone. I'm sure many of you on the call have heard of naloxone. Narcan or Ebzio are the brand names you usually hear of it at. This is a drug that is used to help reverse overdose. Can come in either an injection or in a nasal form. So something for everyone to know about. Naloxone can help reverse the effects of an overdose. The last two on our list here, naltrexone and Vivitrol. These are a different classification of drugs. These are called antagonists. And I'm going to click us ahead to the next slide here as I talk about these. This is, I think, a helpful way to visualize this. So naltrexone is a pill that somebody would take on a daily basis that would help block the effects of opioids. These don't bind to the receptors in the same way, so an effect is not produced. So someone doesn't feel that euphoria that they might with something like methadone, or even the limited effect that somebody might feel with buprenorphine. So naltrexone is a daily pill that would help with this, and Vivitrol, similar to Sublocade, is an injection that somebody might get once a month, and that can be quite helpful with cravings, especially, which is one of the sort of first lines of defense when working with somebody who might have a substance use disorder. These are options. These are not definites for somebody with an opioid use disorder. There's certainly rules of thumb, and there's certainly, from our perspective, a hope that folks will use medication, but it's a very personal decision. It's something that somebody would always want to talk through with a physician and have a good plan for medicine that would fit into an overall recovery plan, hopefully. Lots of benefits if you check the research on medications for the use of opioid use disorders. Number one, if we go back to where we started in terms of all of the deaths that we're seeing and the other consequences related, it improves survival. Folks who are on many of these medicines are less likely to go back to a more harmful version of an opioid. So improved survival deserves an exclamation point after it. That's the most important benefit of medication. It increases retention in treatment. Folks are more likely to stick around in treatment when they're taking medicine, less likely to go out and and return to use of something worse, and more likely to stay plugged into all the other great parts of treatment that we hope people will do, therapy and family work and self-help groups, all those sorts of things. Illicit opiate use and other criminal activity decreases when somebody uses these medicines. Folks are able to gain employment and maintain employment in an increased way. Birth outcomes among women are improved on these medicines, which is really important too. So lots of benefits to using medicine to help folks stay away from opioids. Mentioned cravings a moment ago, and I wanted to go into that in just a little bit more detail. We really want to do our best to normalize cravings for folks. I think sometimes people come to treatment at any level of care and expect that they're going to feel better immediately or not going to want to use. So I think really trying to help folks understand that it's quite normal. In fact, it would be odd if they came to treatment and didn't want to use anymore. So trying to normalize and then quantify how strong is this craving? How severe is this craving? And have people rate it. Is this a passing thought? Is it come and go as easily as it came? Am I entertaining the thought? Am I sort of kicking it around a little more and thinking about, boy, I wonder what would happen if I would use something? Is it more of a preoccupation? Now I'm fixated on it and I can't get it out of my head. Is this person plotting use? How could I get the substance? Where would I need to go? Who would I need to call? Onto the end of a strong urge that I need to use right now. So really helping people understand what what sort of phase of a craving they're in can be really helpful. Helping people understand that a craving is going to pass, whether or not they use, can be really important. Because sometimes the craving feels so overwhelming that the person believes they can't get through it without using, and so they'll end up, going back to whatever their substance might be. But obviously, having a relationship with somebody where they feel comfortable talking through these things can be really helpful. And regardless of which sort of phase, excuse me, they might be in, there's something you might be able to do as a professional or as a helper, right? Sitting with the person, helping them, see the other side of this craving, helping them see, is going back and using something really going to help or not, is it going to create more consequences? So obviously the closer to the left we can keep folks, the better. But all those medicines we talked about a few minutes ago can help manage cravings, as well as other pieces of therapy. So keep us rolling through the other dimensions here as it relates to opioid use disorders. Dimension 2 is around other biomedical conditions, which again, if we think about how significant chronic pain can be to those with opioid use disorders, the other kind of health concerns become very important. So if somebody has, an injury or some other pain, we want to make sure we're aware of that and helping them to manage that, to take care of that. Maybe some other areas, maybe some weight loss might help, or some other, wellness goals around exercise, or something to help their pain apart from an opioid, can be incredibly helpful. Understanding other risks, if somebody has something like, diabetes or heart disease or other risk factors around, Dimension 2 and other health concerns, very important. ASAM's third dimension, emotional, behavioral, or cognitive conditions and complications. So, somebody's mental health history has a lot to say about what sort of treatment they're going to need, right? If somebody comes to see us and they have a presenting problem of, I've got an opioid use disorder, we've got a lot of other questions to ask. And oftentimes we get into many mental health concerns, from, maybe depression or anxiety and PTSD to some anxiety somebody might feel, fear somebody might feel, shame somebody might feel. So all of those things are on Dimension 3. And after someone becomes hopefully stabilized physically on those first two dimensions, we can really dive into the Dimension 3 stuff, really try to get somebody talking to people, feeling safe, trying to identify areas where they might feel safe, physically and emotionally. Trying to help somebody understand their emotions connected to their substance use becomes very important as well. Folks that have been using for some period of time often have really a relationship with their substance such that when they stop using it, while they know it's going to be helpful in the long run, it's still really hard to do, right? There's a lot of loss usually associated with it. There could be a grieving period associated with it. So helping somebody understand their emotions connected to their use, helping somebody understand that these emotions don't need to tie back into a craving. If in the past, when I was feeling depression, feeling anxiety, I had a preoccupation with going back to my substance, how do I develop a new way? How do I cope in a new way? Becomes a really important part of opioid treatment. All right. Dimension number 4, readiness to change. I won't do an entire training here on the stages of change, but it's important to understand stages of change, and what stage of change you're working with in your work with somebody, right? Are they in pre-contemplation? Are they not even thinking about the the uh, the problem at hand? Are they in contemplation in such a state where they're thinking, they're thinking about a change that they need to make, but also thinking about what are the benefits of continuing my use? Preparation. Um, what am I doing to get ready to make a change? Is that where your folks are? Is that where your clients are? Because that looks very different if someone's ready to make change, and the work you might give them to do looks very different if they're ready to make a change as opposed to if they're still feeling a change is not necessary. Action, again, when someone is well entrenched in their change, and then maintenance, when this is just sort of a new way of life and not something that I need to be thinking about with quite so much effort. We want to try to understand somebody's motivation. Are they internally motivated? Do they feel they need to make these changes for themselves? Really understanding that life's going to be better, if I move on, if I make some changes, or do they have more of an external motivation? Are they presenting for treatment, maybe because of legal consequences, maybe because of other family consequences? And I think, again, here's an area where stigma sometimes gets in, but either one is good, right? Either one we can use as the start of change. Motivational interviewing is a great kind of therapy to use to try to really enhance someone's motivation, regardless of where it is, regardless of what area it might be coming from. Dimension 5, we want to make sure we assess someone's relapse potential. We mentioned this towards the beginning of how extremely high the rate of relapse is for opioid use disorders. So lots of awareness for folks around what are going to be their cues to return to drug use, what are going to be, their triggers for drug use. What are the places where they had used in the past? What were the emotions that they had felt when they used in the past? Who were the people that were surrounding them when they had used in the past? Really trying to help folks have a thorough understanding of what sorts of things might cue those cravings, might cue that want to return to drug use. Does somebody have previous attempts to stop using substances? And if so, what were they like? Where did they find success and where did they find challenges? I think this whole dimension number 5 area is a place where we can really do a lot to try and accentuate the strengths that somebody might have, the resiliency factors that somebody might already have, the good coping skills that somebody might already have that they could return to, that maybe they enjoyed at a previous time in their life that we could try to help get them reconnected to. Family comes in here. Maybe if they have some sort of spirituality, that comes in here again, trying to get folks reconnected to things that are, are healthy and are going to feel good. Dimension number 6, the recovery and living environment. So what sort of environment is the person returning to? Whether this is every night if you're working with somebody in an outpatient setting, or maybe this is at the end of a month or more if somebody goes away for inpatient treatment. But what's the home like? Who's there? Is it substance free? Who are the people that are in the home, and how do they either support or detract from somebody's efforts to find recovery? What sort of accesses are there to resources? Are there self-help groups readily available? Are there medication readily available if that becomes a part of it? Are there places for therapy available? As we do this talk now, of course, we're over Zoom, and all of us over the last couple of years have spent, I'm sure, probably more time than we ever thought we would on Zoom. That's become a major issue for folks as well, is just trying to find some connection. So I think we all have a, you know, a job or a harder job than we might have before to try to get folks connected to people, because we know that connection is one of the best ways for folks to try to find success. So with the bit of time we have left here, I'd like to talk about the stigma that comes with not only opioid use disorders, but substance use disorders in general. And I think if you have some awareness here, you know, I know for me, it helps me catch what I'm saying. It helps me catch what I'm thinking. It helps me on a team meeting, maybe hear what some of my peers might have to say and how that, you know, how that might influence the way we think about folks, how we, you know, think about the job that we're doing, and also how folks that are presenting for treatment might already have internalized some of these things for themselves. So a few thoughts here on stigma. Stigma involves negative attitudes or discrimination against someone based on certain characteristics such as mental illness, health conditions, or disabilities. As it relates to what we're talking about here today, I'll submit some of the medicines that we talked about earlier that folks use for treatment. Again, I think I said before, I'm doing my best not to say MAT, which is the abbreviation for medication-assisted treatment. It's interesting how when we're talking about the treatment of substance use disorders, we call it medication-assisted treatment, but you would never think about calling someone's chemotherapy their medication-assisted treatment, right? Or some drugs that somebody might take for a different disorder. But in the treatment of substance use disorders, we do that. We sometimes use that in a way, and sometimes in the self-help group communities, not always, but sometimes there's a real stigma attached to folks using some of these medications. I think it's unfortunate. I think if we look back at some of the benefits, the positive outcomes of some of these medicines, folks have better success. Folks stay alive long enough to do some of the other hard work, you know, that's going to be necessary for sustained recovery. Here's some of the things that internalized stigma leads to for folks in treatment. I think it's fascinating on those two that are italicized, a perceived less social support. So not that they have less social support, but that's their belief about it, is that they have less, that they have less family support, decreased self-esteem, decreased self-efficacy. So this internalized stigma that folks take on, it can really be impactful. And so I think it becomes the duty of all of us to do what we can to try to reduce this. So a couple of slides here to finish us up on how important our language is when talking to folks who come to treatment, but also while talking to each other. And think about maybe other examples as well, but these dialects, if you will, around recovery and how much the words we use matter. And think about the difference between calling someone a substance abuser or an addict versus, on the positive side, maybe a person who abuses substances. Think about, and I even used it in our talk this morning, the difference between saying somebody relapsed versus a recurrence of use, a return to use, an overdose, an addict, an alcoholic, and some of the sort of energy that tends to be tied up in those words versus somebody having an accidental drug poisoning, a person with a substance use disorder. Trying to be more person-centered and less labeling can be really helpful. This I found interesting as well. Just some tips on where to use some of these, some of this nomenclature. It could be that in some settings, as is the first column there, mutual aid meetings. Some of these words might still be, kind of part of the norm or helpful. But again, in a professional setting, with clients in a medical setting, it can really be helpful to be mindful about, the words we use and the way we talk about the work that we're doing and the folks that we're trying to help. So this was an area for me that I found really interesting. I'd encourage you, there's videos out there, all sorts of good information about how the language we use sometimes reinforces these stigmas and these negative messages that, can help keep folks stuck in their substance use disorders. So a couple pages here at the end on some resources and some references. And Ken, I will send it back your way, sir, if you have any questions that have rolled in while we have a few minutes here.
Chris, thank you very much for your thorough explanation and experience of opioid use disorder. We will now answer some of the questions that were submitted through the registration process. Chris, let's start off here. So, in your opinion, what are we missing as overdose deaths continue to rise? Could you explain? Thanks.
So that's I think really the biggest issue as it relates to the use of opioids. So many deaths. I think I don't think I said the word fentanyl yet, but fentanyl is a huge problem. Folks get fentanyl mixed in with other drugs. They don't know it's there. There are, many times substances might be purchased and someone might think they're sort of buying one thing, but it's really got other things in it. There's a sort of a culture at times where, if there's a batch of drugs and someone uses and does have a death related to that, other folks will kind of flock to that street corner and look for the same substance because they think it must have been, more potent or stronger. So there's so many issues related to overdose deaths. There's culture, there's, the need to intervene earlier in people's lives, in people's, substance use disorders. If you look at substance use disorders, they can be, classified in 3 different ways. Mild, moderate, and severe. Trying to find ways to intervene earlier becomes very important. I think doing things like this and making sure everybody's talking about opioid use disorders and how to help them, that can go a long way as well.
Thank you, Chris. Number 2, how could you describe how faith communities can help?
So good question. I think when we talk about opioid use disorders, there are, a lot of sort of medical pieces to it. What medicines are we going to do? How are we going to make sure somebody, detoxes safely? But there's all sorts of other avenues for folks to help as well. I think, faith-based communities, helping people get connected. I think one of the real important pieces of recovery is having a purpose. Pardon me, feeling like I'm a part of something bigger than myself. So, whether that's sort of more traditional religious institutions, helping people get reconnected to religion, or helping people understand spirituality. I think, faith-based communities that can be just open and accepting, I think getting educated, those are all ways for faith-based communities to be a great help.
Thank you, Chris. Chris, can a patient stay on Sublocade long-term? And what are the risks and benefits of doing so?
So I guess it depends a little bit on what you mean by long-term, but yeah, I think Sublocade can be something that someone's on for a year or 2. If they can find a way to access it. I think we didn't talk a whole lot about access here today, but that's one of the challenges at times is sometimes folks in need of treatment, whether that's medical services or more, therapy services, accessing treatment can be challenging. But if someone can access it, yes, they could be on Sublocade for a year or more. I think pros to that, as we saw before, are numerous. Folks usually have a better shot at work and other meaningful activities in life because they're less likely to go back to some of those illicit drugs and the behaviors associated with them. I think in terms of the downside to that, there are times when, especially with Sublocade, somebody might have a reaction, a physical reaction, an infection under the skin. Again, there are still folks who sort of look down, if you will, on folks who are using buprenorphine products because they feel like it's not real recovery. So I think sort of being ready to understand that opinion is out there is going to be important too for folks that go that route.
Thank you so much, Chris, for answering a few of the questions that came in during the presentation. I want to thank you again for your informative presentation and to all our attendees for joining us today. As a reminder, this presentation is eligible for 1 continuing education credit. Watch your email for a link from cego.com to complete your evaluation. Before we close out today's session, I'd like to share some upcoming webinar opportunities available from Caron Treatment Centers. Please save these dates. On February 9th, we are hosting a webinar entitled The Intersection of Adolescent Mental Health and Substance Use Disorder. It has been approved for 1 credit and will run from 12 p.m. to 1 p.m. And then on February 17th, we are hosting the Neurobiology of Addiction. This has been approved by the New Jersey Association of Osteopathic Physicians and Surgeons. It designates this educational activity for a maximum of 1 AMA PRA credit and 1 AOA Category 1A CME credit. This will run from 11 a.m. to 12:30 p.m. And then finally, on February 23rd for the month, we will be presenting a webinar entitled When Success Leads to Failure, Substance Use Disorder Among High-Achieving Legal Professions. It has been approved for 1 credit and will take place from 12 p.m. to 1 p.m. We hope to see you again at one of these virtual events. In the meantime, please reach out to one of your local regional resource directors at any time for additional information, resources in your area, or questions regarding admission to any of Caron Treatment Center programs. Thank you for joining us, and I hope you all have a fantastic afternoon.